We're good to go.
You let me know when you want me to begin to record.
You can start now.
Are we on?
We are on.
Great. Good morning, everyone. Buenos dias. Thank you for joining us at this very important event. My name is Adán Colón Carmona, a professor of biology at UMass Boston, and I'm a member of the Latinx Knowledge Hub. The Latinx Knowledge Hub is a collaborative of medical doctors, public health experts, social scientists, and policy professionals from across Massachusetts, public institutions of higher education, independent policy centers, and community organizations. We are working together in the development of equitable solutions to major equity and health challenges, such as the opioid crisis, the topic of today's webinar. Without further ado, I would like to introduce the moderator of today's conversation, Dr. Sánchez. Dr. Sánchez is Medical Director of the Infectious Disease Bureau at the Boston Public Health Commission, and she's a clinician at Mass General Hospital's Sexual Health Clinic. Dr. Sánchez.
Good morning, everyone. Thank you so much for being here today. Do we have, I just want to pull up our slides. Thank you so much for being here today for our session, Voices from the Field, and really trying to dig a little bit deeper and best understand the opioid crisis in Latinx communities here in Massachusetts. I am very honored to be with speakers who really represent our voices from the front line across the state of Massachusetts, including Springfield, Worcester, and here in Boston. Next slide, please. Oh, perfect. And so we will have three panelists here today, Dr. Matilde Castiel, who currently serves as the Commissioner of Health and Human Services for the City of Worcester, Soloe, who works as a Director for the City of Worcester Division of Public Health, and Dr. Zhen-Duan, who works as a psychologist and researcher at Massachusetts General Hospital. Next slide, please. And so a few of the underlying, really having the richness of all of our panelists here today who really offer a frontline perspective to best understanding the opioid crisis here in Massachusetts, and with a particular focus on our Latinx communities. We have a key set of 4 questions that they have each been asked to answer with the expertise that they bring from their own experiences on the ground and their own work in community health and public policy and their clinical research as well. Next slide, please. And I think I wanted to offer a few contextualizing slides to highlight really why we're all here today. And that is because the opioid crisis remains a public health emergency. It was declared a national public health emergency in 2017. And we continue to see the opioid crisis detrimentally affect our communities. And in recent years in particular, there has been a demographic shift with increasing rates among Hispanic Latinx individuals. Many of us here know that our Hispanic and Latinx community is rapidly rising in the United States, and that there are specific, oftentimes cultural, socioeconomic aspects, language aspects unique to our Latino community that are essential to best understand how to address these issues from a public health and a clinical standpoint. Now, in 2020, SAMHSA published a report really highlighting the urgency of addressing the opioid crisis in the Latino community, and with a particular focus on some of the challenges that remain with best understanding data. But what was unique about this report is that it really brought a lot of frontline voices and sort of some of the key experiences across the nation in terms of different models that helped to best address opioid use, opioid overdose, and substance use generally, as well as mental health in our Latino communities. And so it was particularly focused on initiatives that worked well within this group. And part of what I want to highlight with the upcoming slides is that this is a critical issue in both Boston and in Massachusetts, where we see that opioid, particularly as it pertains to opioid overdose deaths, as well as opioid misuse, when we look at our statistics, we know that particularly in our Latino, Hispanic, Latinx groups in Boston, we've seen rates rise over coming years more than in other racial and ethnic groups. And when we look at opioid-related mortality in Massachusetts, this slide here shows mortality across different years and by different race and ethnicities, particularly amongst males. And this is data from the Massachusetts Department of Public Health. We can note, if you take a look at the red bar, that it looks a little bit small, but if you take a look at the red bar amongst Hispanics and compare it with sort of the rates among white, Black, and even all races generally, we see a higher rate of opioid-related overdose deaths. And I think, again, something important to keep in mind and really highlights the importance of the conversation that we're having here today. Next slide, please. And so again, I will bring it back to our panelists because they are truly the voices that we all are eager to hear today. And the 4 questions that we are asking of each of our panelists, which is to provide an overview of the opioid crisis in our Latinx communities and the experience that they have had, to best understand what we need to tackle the crisis at each of our local, state, and national levels. What are some of the challenges in accessing services for individuals from diverse Latinx communities? And importantly, are there gaps in data that are tracking the crisis? And how do we address those gaps, or how each of them have addressed these gaps with their work? And so here I will take a pause and introduce our first panelist, who I am again so honored to be here with, Dr. Matilde Castiel, Dr. Mari Castiel, who serves as the Commissioner for Health and Human Services for the City of Worcester. She is a seasoned clinician, board certified in internal medicine, and has had decades work, previously served in UMass Memorial Medical Center, Family Health Center of Worcester, and also serves as an associate professor of internal medicine, family medicine, and psychiatry at the UMass Medical School. She oversees the divisions of public health, youth services, human rights and disabilities, veterans affairs, and elders affairs, and homelessness, and has extensive experience in leadership in advancing innovative clinical programs and public health initiatives addressing homelessness, mental health, and the opioid crisis. Dr. Mari Castiel, I will turn it over to you.
Great, thank you. It's a pleasure to be here today. I'm going to, let me see if I can request remote control. No, I don't want to give it up. Wait, request. Okay. So I'm going to start by telling you in a lot of ways how to solve what we did in our community to solve some of our issues. If you can go to the next slide. We looked at addiction. We started a program, and this is sort of what I believe, that we can actually work together, even from physicians, to say these are issues that are happening in our community and how do we change it. So in 2009, we opened the program, and we started the program by really providing the data that Latinos were about 18% of the population, and they were 24% of the substance using population in our community. And we knew that communities of color tend to receive a lower quality of healthcare than non-minorities, even when access-related factors such as patient insurance, income are taken into account. So we knew that as a background moving forward, why we needed to do this. So next slide.
You can double click.
Oh, sorry, I can do it. Okay. Do I get in here first? So we met, so Hector Reyes was a gentleman from the community who I got to meet. Most of you know probably in my time, addiction wasn't something that was taught in medical school, and certainly something that we didn't practice in. When we saw somebody in the emergency room, we actually just did the basics and then sent them out and gave them numbers. In some ways, we still do that today, so things haven't changed a whole lot. But he was a gentleman who wanted to put a treatment facility for Latino men because Latino men did not feel comfortable going to regular programs. They didn't feel they didn't speak the language. The customs weren't the same. The food wasn't the same. And when they spoke Spanish, they weren't accepted. So the program that we started in 2009 was called the Hector Reyes House. And unfortunately, he died July of 2009. But we continued the program until continues today. And one of the things that we noticed when we were starting the program is that you get that whole NIMBY, nobody wants you in your backyard. We don't want those people with us, whether they were homeless people, they were people with addiction, they didn't want it. So you really had to go knocking on doors. And this is probably, and this was where I think being a physician became a great thing, because a lot of the people in the neighborhood knew me as a physician. So you can actually see Latino drug rehab greeted. It doesn't happen in our community. It's a very difficult thing to put to get a program, and especially when we're talking about Latino program. because the stigma, the racism still exists in our community. Nobody wanted to have this program, and when it came to government, they didn't want to take something that could pay taxes off the city rolls. So we bought this house from a nonprofit, so nonprofit to nonprofit, and it was easy to put this program together in that sense. One of the things that we looked at, I'm probably going to go back just to tell you that part of the idea of it is also, most of you know that our community has been incarcerated for addiction for generations now. It's been a process, and really, I can say that it increased even more in the 1970s with the war on drug. And at that time, if you were caught with drugs, the first time it was 5 years, the second time would be 10 years in jail, and the third time would be 15 years in jail. So people who come to the house have been homeless, have been incarcerated, have not had an education, have not had any job training. So really, this is what we were dealing with. We went to the university and asked to have psychiatry come into the program. And remember, this is times when people weren't even talking about other medical pieces that could be added to the program. So psychiatry is part of the program, infectious diseases in the program. And then when people were in the program and we did this, we realized when they were graduating the program that there was no housing. To this day, there are no housing in that sense that's safe for people to go to. Some of the things that we developed along the way, at the time when nobody was even speaking about the social determinants of health, that housing was an important piece, that education, that jobs was important, we started transition houses. This is the first transition house, which is Casa Reyes. 9 residents live here. This house we just purchased 2 years ago, and it's Casa Mari, so that people can graduate and at least spend some time in transition housing before they get their own apartment. We wanted to make sure that people know that they deserve to live in a place that has dignity, that has everything that anybody else should have. And so the houses, I always say, were better than my houses when my sons went to college. When we did the transition houses, we knew that people couldn't get jobs. It was difficult to get jobs or jobs that even paid reasonable money. So one of the things that we did, and again, I talk about that the only thing I knew how to do was medicine and cook. And so we opened up a restaurant. It's a Cuban restaurant because I'm Cuban and that's the only food I knew how to cook. And so we opened up a Cuban restaurant to not only to teach them to become prep chefs, but also to learn to cook for themselves. And most importantly, is for them to come into contact with the community, that people in the community, when they come and eat, they know that everybody there is in recovery and they're no different than anybody else. How do we change the stigma? That was part of the process of how we do that. Great food, and I think it's an important piece to bring about. I show this slide because we also partnered with Consigment Community College to show our guys how to become prep chefs. And as you can see, this came out in Worcester magazine, changing the language, making sure that we change the language for them, making sure that they understand that they're people in recovery. They're not defined by the words of addicts or anything else. And so, and really changing that in the community. Am I going down? Then I think a lot of it is building family, building community, people accepting people, bringing them to your house, but showing them that you care. We did a lot of celebrations together. We did a lot of trips together. People have missed a lot in their lives. And so how do we bring it all back so people can actually be a part of the process? Just on Wednesday, we had a graduation. I just want to show you a quick clip of what this is like, because this to me touches your heart. To see men graduating. This is a 6-month graduation, and then they can move on to the transition house from there. That we appreciate them, that they deserve this, but also to remember that it's a long road ahead. Remembering that this is a disease process, and that relapses are common, but we are there at any point in time to be able to bring them back into treatment and talk to them. They have my phone number. If there's any issues, they can call. But I just wanted to show you this piece. We give them the coins, 6-month coins. It is a medical treatment facility in the sense that I provide primary care, psychiatry, these clinicians. I'm gonna talk a little bit about what is needed, because in 2015, I came to work as Commissioner of Health and Human Services for the city of Worcester. A lot of what I've been doing there is I have reentry task force to really look at what happens in incarceration, to really be able to train people there. I'm not a believer that we should be incarcerating anybody with substance use, and we should be treating them medically. I don't believe that police should be able to sort of treat people when they've spent most of their time incarcerating people. So I want it to be that public safety is actually looking at drugs that are coming into the community, and how do we stop that? We look at different ways of harm reduction. I'm a proponent for safe consumption sites. Anything that we could do to be able to prevent overdoses for us in Worcester. We've had 153% increase in mortality from last year to this year. And we know that Massachusetts saw a 1.5% decrease in mortality overall, but for Worcester, that number has increased, and certainly has increased in the Latino community. Homelessness is a huge problem in our community. I would say 3/4 of the people that come into our program have been homeless in the past. And so really trying to work with homelessness in our community, to provide housing, is an important piece that we need to advocate for. And we continue to work not only on stigma with our residents who continue to call themselves addicts, or feel that they did it to themselves, and actually to be able to tell them that it's about it's their trauma when they were kids. I don't think there's been very many guys who did not have trauma at the age of 13 was the average age. Family members who may have been using drugs. And so that's been a progressive thing. And so how do we work on building them up? We've done data looking at touch points in emergency rooms when somebody comes in. And we realized out of 300 people that we looked at an emergency room, 4 or 5 were transferred to primary care. We have a bridging clinic in our hospital. None were transferred to the bridging clinic. So having access to all of this never happened. And still trying to figure out to working with them to be able to connect them to the services that are outside. So that's the process. We have an equity task force looking at trying to get data and from our community. We're working with somebody to do that. We did all the data during COVID, and trying to find out that we can do that now. And so we're just about to engage with somebody who will be able to provide the data. But meanwhile, we were looking at opiates just to look at what we thought we knew. And part of it is we know some of that information, but we needed to show to the community that people are coming in with overdoses. They're not being connected, not even to a bridging clinic. And this is not just of our hospital. This is everywhere that you look at. It's what's happening. And so how do we work with that and change it? And certainly we need more programs that are tailored to the Latino community. And certainly we need more women program also. So thank you.
Thank you so much, Dr. Castiel. I will now, I welcome questions. I don't see any questions in the chat just yet, although I'm sure we'll get some along the way. And I will now pass it to Mr. Soloe Dennis. Do we have slides for?
No.
Oh, perfect. Okay.
I do not have slides. I just want to say, first and foremost, thank you so much for giving me the opportunity to share my view. My name is Soloe Dennis, and I'm the director for the Division of Public Health in the Central Mass Public Health Alliance. I was invited here to talk about my experience working in the Latinx population in the city of Springfield as the Deputy Public Health Commissioner. My work as a public health practitioner was to look at how can we provide services to the Latino population, but also the Latinx population. My view on this work for the past 10 years has been trying to make sure that we have relevant, culturally sensitive services that folks in the population can relate to. My experience is a lot of time we talk about opioids and death rates and substance use as misuse. The challenge we face at the local level sometimes was we have funding, but the funding was not complete enough. The funding source could last for 3 to 4 years, As a result, the services we have implemented lack because we had to make sure that our funnel and the deliverable was met. So I think where I sit today, working in Worcester, but also working in the city of Springfield, it's an ongoing challenge in terms of how can we look at services that are culturally relevant. How can we engage the population that a voice that can advocate for them? I think Dr. Castiel touched on a lot of important points. One thing I would like to talk about is having more diverse staff, more diverse services, and more information about the services that is available. One of the things we worked with in the city of Springfield was bed availability. So a lot of times when folks have come forward and said that they needed services, there was no bed available for them. And as a result was, they felt that we didn't have the services, but the services was there. The challenge was if a male or female approach those programs, when they get in those programs, some of them, because of their lack, because of the services not in tune to the cultural sensitivity, they can either get expelled from those services, from the programs. As a result, they become homeless. And also as a result, they become less interested in us working with them. So for my point as a public health practitioner and administrator is, I think our goal was to develop a system. How can we have an honest conversation around having transparent services, having services available, but also having resources available the day that someone may say that they need help. I think my approach and our approach in the field of public health is to make sure that we bring services to the folks that need it the most. We cannot sit behind our desk and talk about substance misuse in the Latino population and don't have enough recovery coaches and don't have enough folks that have labor experience to actually do the work. You know, doing this work has been very interesting in terms of navigating some of the historical norms and misnorm information. And so as we move out in this whole processes, I think one thing I would like to share with this group, but also the listener is we have to be more considerate. We have to be more engaged, but also we have to be direct in terms of the needs of the community. Institutional racism still exists. Certain folks have been stigmatized because of the way they look, because how they talk, and we need to look at how can we actually try to address that, right? In terms of data, one of the challenges we face in terms of data is we don't have real-time data. A lot of our data is 2 days, 6 months old. So as a result, it's very challenging to have a better picture in terms of where the services lies, which drugs is coming to our community, and how can we use that data to share with our community partners, but also look at resources that we could leverage and to actually have an understanding in terms of some of the needs in the community. I will end by saying that this work we do is an ongoing work. It's something that we need the community to be part of this process. And in order to be part of this process is we have to be engaged. We have to be more delivered in terms of grant funding. We have to have targeted funding to community of colors, to Latino community that are actually doing the work. That way we can have a better result, because a lot of times, as I indicated in my opening remarks, is a lot of the funding we get is not sustainable. So how can we look at the funding mechanism to have something that is actually lasts for 5, 10 years and not for a 2-year period? Thank you.
Thank you so much, Soloe. And I really just want to praise your astounding leadership in this field as a public health director for the city of Worcester and as our deputy public health commissioner for the Department of Health and Human Services in the city of Springfield as well. I really just want to commend your leadership and extensive experience in this field, and prior work for the Massachusetts Department of Public Health as well.
Thank you.
Thank you. I didn't get a chance to introduce that. I just wanted to really, again, praise and commend all of your work. I see a few questions coming in the chat, and I think we've touched on a few themes that I think, at least for me, have really resonated from your and Dr. Castiel's, different stories, which highlight, I think, a lot of the aspects around stigma and really trying to have culturally responsive interventions. And I see a few questions in the chat. One of them towards Dr. Castiel, although Soloe, I also welcome your input and others here. The question says, Dr. Castiel, you advocate for more Latino programming. We all agree. Are there specific culturally responsive aspects of treatment and recovery support that you recommend?
I think I wrote it on the chat that.
Oh, thank you. Yes.
But that everyone is, from staff members to the staff, to clinicians that are there, to the doctors that come in, everyone is Latino. The food in the house is Latino, even though we try to show them how to make healthy Latino food and stop the frying and all of that. But how else can we do some of the frying? But also, I think for all of us is providing what we call familia. I think we all, that's the goal, is that we are together and we're together in this. That's how we all feel. My goal, their goal, is to really make them successful. And to be proud of who they are. They are Latinos, we are Latinos, and we are successful, and we can be successful. So I think it's that for me is it, and the passion that we have to do this because we care.
Thank you. Thank you. I don't think I see other questions, and so I will move. Thank you so much, Soloe, and I will move to our final panelist, Dr. Jenny Zhen-Duan. Dr. Zhen-Duan is a clinical psychologist at Massachusetts General Hospital and a clinical investigator for the Disparities Research Unit at Mass General Research Institute. And they actually contributed to the findings in the SAMHSA report that we highlighted at the introduction, highlighting the urgency of this issue and sort of findings from their investigation related to community-based research. Dr. Zhen-Duan's particular research actually focused on racial and ethnic disparities in mental health and substance use, with a particular focus among Latino youth. And so I am so excited, Dr. Zhen-Duan, to have you here today and to hear from your experience.
Thank you so much for the introduction and really great presentation. I really admire the efforts you both are making in the communities. And actually, my presentation is I'm gonna focus to better answer some of the questions that are posed. I'm gonna talk about like one specific project, huge project, like lasted 5 years with the state of with New York State. But you will see that there's a lot of overlap with Massachusetts, and it's gonna thread really nicely across like themes that you have both been discussing today. So the title of my presentation is Improving Opioid Use Treatment in Latino Communities Through Upstream Partnerships, and I'll explain what that means. And before I do that, I'm going to talk about the title of the project. It was the principal investigator was Maggie Alegria. She is my boss and mentor at MGH. And the project that we're working on is looking at the impact of Medicaid plan on access to and quality of SUD treatment. As you know, you both talked about the insurance, being able to get treatment, but before we even get to that, a lot of people need to have insurance. And like one of the benefits in New York, for example, is that even undocumented Latinos can have some type of health insurance. And when we look at Medicaid, because so many of the Latino communities are represented by Medicaid, are low income and need Medicaid, we want to see like, well, is Medicaid doing its job? Is Medicaid providing good treatment for people that need substance use disorder treatment? So it's a mixed method study. The first part is quantitative. New York State actually sent us the claims data from 2005 to 2017. And one of the methodologically neat things about looking at the Medicaid claims data is that the people who like sign up for Medicaid are randomly assigned into different managed care organizations. To give you a very basic example, when I moved my family from Puerto Rico, I signed up my mom and my grandpa to Mass Health as soon as they got here a few years ago. And my mom got randomly assigned to like Tufts, and my grandpa got randomly assigned to United managed care. So they're both Medicaid, but they're different managed care. And why does it matter for researchers? Well, when we think about like clinical trials, we are always thinking about assigning them into like different control and experimental groups. When this happens naturally at the Medicaid level, what we should find, the hypothesis is that because they're randomly assigned, if all else is equal, all Medicaid managed care organizations should be performing the same, meaning United and also Tufts should be performing the same, like should be providing the same level of good quality service for substance use care. So we were testing that. That was a quantitative piece. And some of the metrics assessed was like access, patterns, and outcomes. Dr. Castiel mentioned something like when people get to the ED, how long does it take them to get connected to primary care? How long does it get connected? How long does it get for them to get Suboxone, for example? So those are some of the metrics that we are assessing. And we have a huge database. We want to look at the trends, but we're also, because we all are interested in the disparities piece, we stratify the analysis, like, does it differ by race and ethnicity? Does it also differ by gender? Does it also differ by rurality? Like New York City and New York State, do they have different patterns in access and quality of care? And then the qualitative piece, now we were expecting that to find significant issues with access, patterns, and quality of care, right? Because like the data shows that we were also expecting to find some disparities by race, but knowing that these disparities exist is not enough. We wanted to understand like why are these things happening? What are some target areas that we can focus on? What are some of the suggestions that people have that really have the lived experience that are providing these services have for us to suggest like practice and policies changes. So the stakeholders that we interviewed for the qualitative piece, we interviewed over 90 people. They're policy leaders, policymakers, also patients, clinicians, and also Medicaid managed care representatives. So we interviewed over 10 different people that worked in over 10 different managed care organizations. And one of our partners, and this is what I mean from like upstreaming intervention partnerships, was OASIS, which is the New York State Office of Addiction Services and Support, which is an agency that oversees one of the US largest SUD systems of care. And this was very crucial for me and for my learning experience, but also from my policy work, because they were our partners. They were really interested and really invested to understand like what we're finding and also bridge some of these policy gaps that people were like experiencing. And it was great because it was the first time that we were like kind of feeding them the data as we got them. And they were saying, they were identifying like some areas that they wanted to focus on to improve substance use disorder care in the state. So what did we find? In the quantitative piece, we found that after evaluating 159,000 individuals' claims, we found that all plans achieve less than 50% most performing measures. What that means is that people are not performing, Medicaid organizations are not performing well in terms of like SUD metrics, like the one I mentioned, for example, is how quickly, or do people that go to the ED after an overdose experience, do they get connected to like some other outpatient care within the 30 days? Well, we see that they're not. Most all Medicare organization in New York were not achieving that. And then the only one that was over 50% was engagement in opioid use disorder pharmacotherapy, getting medicine. And that was at 58% average from 2009 to 2017. And I really credit the state for doing all the effort that they did to really get people connected to like the medication that they needed, especially with like opioid use disorder. There was also significant expenditure variation among plans. For example, Plan A had this amount budgeted for substance use disorder treatment, but Plan B had a lot less. And some of the plans actually didn't have almost any money. And you can see the difference because of that. So it's not random. I think that even as myself as clinician, I don't think about like what type of insurance people have when they come to see me and how the decisions that are made more upstream actually can affect my face-to-face interaction with them. And in a follow-up study, we also found treatment disparities among Asian and Latinos, but not Black participants, enrollees, I'm sorry. And we highlight that the lack of culturally and linguistically matched services is to be attributed for these treatment disparities. And one very specific example with Asians in New York, for example, the clinicians were telling me that there were no like higher service of care for like inpatient, for example, inpatient units that were equipped to take like Chinese patients that had more severity, acuity in their symptoms. So they had to be seen at more like outpatient level care, which was not the most adequate for what they needed in the moment. But because of that language and cultural mismatch, people were not going anywhere. And that's actually what Dr. Castiel had mentioned too. Like people were just like, a lot of places, like a lot of people didn't know where to go. And the language is such a big factor. And then in terms of the, one of the questions that we had was, I'm being mindful of the data, are there any gaps in data? Well, one of the common challenge, and I don't know, like people just know this, is that analyzing disparities in Medicaid population is that we have a lot of missing and invalid codes for race and ethnicity. So it's really actually really hard to stratify, to even identify in the first place, to identify the Hispanic population and manage care, because the data quality for race and ethnicity is so poor. So we did have some strategies that we use to make sure that we cross-reference and make sure that the Hispanic population was represented and accurate in our database, but that was not a very straightforward thing to do. And I'll share the papers if you are interested in what we did. And in terms of the qualitative data, we found that many people found the quality metrics and assessment not very useful. For a lot of different things. So one of the participants and the policymaker said, I think Medicaid data itself, the records that you have now, I think would not allow for any type of analysis about patient experience. There would be a lot of assumptions. It looked like this patient or this person was continuing with care, and then all of a sudden they stopped. We don't know what that means, right? Does it mean that they disenrolled? Does it mean that this person in New York moved to Massachusetts? Does it mean that they had a negative experience with like the primary care doctor, for example? We don't know. We just know that they stopped. And one of the criticism, from these 90 interviews that we did from like different policymakers, one of the biggest criticism is that actually what the quality, the quality metrics are assessing is like actually plan performance, how well the services are being rendered, but they're not really focused on like the patient experience. We're not really assessing like what patients really need. And so I'm going to skip that for now, but I'm going to also summarize the qualitative information. Despite the challenges, patients and clinicians emphasize that Medicaid is the best insurance to cover SED, which is actually treatments, which is actually very consistent with what we found with, comparing previous literature, comparing private and public insurance. We do find the Medicaid as better services and expenditures for substance use disorder. So there's more reason for us to improve what we can do through Medicaid, especially for the Latino community. But there's also a lot of bureaucratic challenges that can seem to be like easily fixable, that the state and Medicaid can also focus their efforts on. For example, income fluctuations. Some people, even patients, were describing like, well, I wanted to work, and then once I started to work, I would lose Medicaid, hence I would lose treatment. So how do we also address like those income fluctuations to make sure that patients do not lose access to care? Transition from jail to prison was a huge issue. A lot of people were not getting the services they needed or did not have insurance as soon as they left jail or prison. Address requirements, Dr. Castiel mentioned, a lot of people are experiencing homelessness. They don't have an address. So that was also an issue. Switching managed care, and then that specific clinic that they were going to no longer accept their insurance. And the biggest, and Dr. Castiel also mentioned this in her personal experience with the men, is that it also fails to address the social needs. So one of the biggest thing is that, we see patients, I see patients, I have seen patients for substance use disorder or opioid use disorder. And are we really as, a healthcare system asking them like, do you have food today? Do you have places to live? Does your children have transportation to their school? So looking at the social needs is also part of the good, providing, is also essential to providing good quality treatment. And then peer support are perceived as a key component for treatment, but a lot of the managed care organizations don't have the capacity to like allow for reimbursement for that. So that's like one of the specific places for us to, that we can address, target. So I'll go through it. I'm sorry, I'm going through this very quickly, but other questions also was like challenges and areas to tackle. The good news is that we did a lot of the work. We have a lot of suggestions from people with lived experience, from people who provide services day in and day out, from Medicaid, from like policymakers, and we synthesized like what are some of the issues that we're experiencing. I already mentioned some. But some of the suggestions for improvement, and this is like maybe some of the things that I'll leave the everyone with, are some of like, are these some of the suggestions here, like some of the things that we can tackle in the states to address opioid use disorder? Can we not require waivers to prescribe buprenorphine? Can we make pre-authorizations easier or not required? Can we waivers, getting waiver to provide medication was described as difficult for a lot of participants. So can we make them more accessible? And actually this training online became a thing during the pandemic, because a lot of the interviews we also did pre-pandemic, during pandemic, within the pandemic, but also like expanding who can provide medication, like NPs, PA can administer, and incentivizing providers to provide medication treatment, lower the bar for provide medication. And I have some clinicians to say, I would love to have a backpack of Suboxone and provide them, go to the park and say like, hey, you want a treatment today? So really low barrier to providing treatment was an ideal suggestion for improving treatment and care. And then also the second part is responding to patient needs. So embracing harm reduction strategies. Like a lot of the patients would really describe like they had a really positive experience just having a place to go that identified themselves as like a harm reduction clinic, and they didn't have to, they could literally go if they wanted one day to just do needle exchanges rather than get treatment or see a doctor, and really meeting where the patient is rather than like saying like, well, you either are in treatment or you're not. You're either abstinent or you're not. So really embracing harm reduction and meeting them where they are. Peer specialists, increasing warm handoffs in hot handoffs. That we did a lot of that at BMC with OBAT when I was in primary care, really like seeing patients for therapy, and if they express any interest or interest for information or interest in treatment for opioid use disorder, I would literally walk them to OBAT, which is like down the hall. And that would also, we've seen by the research that actually also improve the treatment experience for a lot of patients. And then the last thing I'll mention is making sure that there's investment in hiring providers that are a racially cultural match of the intended population. If we're wanting to tackle Latino opioid use, we have to also invest money in training and recruiting, not only peers, but also providers at different levels to be able to tackle this problem. And that is it for my presentation. I am happy to share the presentation and also the papers with the actual PDFs with people if they are interested in that.
Thank you so much, Dr. Zhen-Duan. I really just want to highlight, I think your presentation really hones in on the richness of listening to people's voices and qualitative, and the role of community-based participatory research at times, or even qualitative data, and just helping us understand the voices of people on the field, our clients we want to serve, and also are we asking the right questions? I think that oftentimes to ask the right questions, we need to hear directly from sort of experience on the ground. And I think that sometimes some of the challenge with data is that we might need to turn to sort of our own patients for some of this data for better richness. And so thank you. And on the last point that you mentioned, we have a few questions in the Q&A. And actually one of them is really related to the thoughts about promoting staff diversity. So I think this was directed towards Ms. Soloe Dennis. But I welcome others as well input because it's a pretty common theme. What are your thoughts to promote staff diversity among the public health workforce, especially support immigrants who come to the United States with licenses or certifications, and yet they are not allowed to join the health field, neither can access the appropriate training? Soloe, I'll start with you and then sort of welcome others' input.
So I would say that we have to seriously think about that because the population we serve is changing, so we need to adapt, and the workforce need to be more flexible and diverse. That way we have a better understanding of the challenges. You know, we are very lucky in the United States to have a variety of folks that comes to this country to improve their life, but also to provide better life for the family. And these folks have lived experience, and we need to literally think about that in terms of your health, mental health, and how can we integrate that into the workforce? Because workforce diversity, I believe, is one of the key in order to address a lot of the social determinant of health that we face in the Commonwealth, but also in the nation today.
Thank you. Others? Dr. Zhen-Duan, Dr. Castiel?
I guess for me, it's an important thing, and speaking about Latino, I think we need to get more Latinos to be part of public health, and I work hard to get more Latinos in there. I think the piece about the licensing is tough. I mean, I think the city does not accept it yet, and it's something that we're working on. I know we're looking at, sort of increasing that diversity. They know that that's an issue and that we have to move forward. We still hire people, and I know it's not the same, unable to use those licenses, but bring them into the city to start the work as we then continue to promote through the city that licenses should be accepted, and then certainly moving up to the state to be able to do some of that too.
Thank you. And I see one other question in the chat. So a few others actually. So for Dr. Zhen-Duan, thank you for your presentation. Do you have plans to expand this work to Medicaid in Massachusetts?
Yeah, so actually our team was approached by Massachusetts to do a similar work, but we have not agreed to it yet. I think a lot of things have to come, kind of line up, but we're open to doing that. And actually we would like that to do that. And the reason why we focused in New York was because my supervisor, Maggie Alegria, had already some experiences and some partnership already with OASIS in the state of New York, and they have funding to do some of the preliminary work and some of the actual intervention work in the community. So there was already a relationship with Maggie, and that kind of transformed to a NIDA funded project. But I think those relationships were not the same for her here in Massachusetts, but I'm very willing to expand this work to Massachusetts. This is where I live. The patient population is like, this is where they live. So I'm interested, but no concrete plans yet.
Thank you. And then, for all panelists, I welcome input. How do mental health parity laws bridge the divide between access to healthcare? Only states with comprehensive parity also include substance use disorder treatment and parity. New York and Massachusetts have limited parity. And so what could be the role of comprehensive parity in greater access to healthcare for our patients? Dr. Zhen-Duan, I see, or others?
I mean, certainly mental health is an important issue that we have, and parity is important. I think we are, part of our problem becomes more the shortage of clinicians that we have. And then we talk about the shortage of clinicians that actually speak Spanish or are Latino. And so that is huge. There is a waiting list to get people in, and so that becomes even more difficult. And that's one of the reasons that we actually brought in clinical people from UMass, psychiatry from UMass, and clinical people into the program, which is now a requirement for BSES, but we've had it since the beginning because it's difficult to access. Not only that, culturally, people don't accept mental health issues or don't accept seeing a psychiatrist. But once we bring it in so on their own, they wouldn't do it until they learn that process through programmatic so that they know that that's something that they can do. It's still difficult to get access. I think it's hard. I think it's almost harder for somebody who has insurance to be able to access mental health. But overall, for us, it's having mental health clinical people to speak the language that people feel comfortable and can do it, and certainly changing that cultural piece that it's part of treatment.
Yeah, and my impression from talking to policymakers who are, and clinicians and that are really thinking more about parity laws and how these affect like face-to-face interaction. I think that this is, and based also, I conducted almost all of these 90 interviews. A lot of the patients were also Spanish speaking. And I think that it is an issue, but I think that based on like our results and what we found, because I thought a lot of them were going to be more policy related, there's a lot of barriers at like different levels, not only at the, laws. And I agree with like what Dr. Castiel mentioned, like the just getting into treatment is extremely difficult. And when you get into treatment, there's a lot of provider stigma, and a lot of the patients that I actually interviewed in 2019 had just migrated to New York after Hurricane Maria. So they were experiencing a lot of like traumatic stress from the hurricane and all this stuff. Well, some of the Puerto Ricans that I interviewed, and really didn't like speak English. So their experience in like setting their foot in their first like clinic or harm reduction center affected a lot how they perceive treatment in the US, right? And I think that's also true for a lot of Latino immigrants. So I think not the laws are like a big part of it. The parity laws are also a big part of it, but there are a lot of barriers and also opportunities throughout the treatment continuum that I think we can look at.
Thank you. I'll make a plug for attendees for any last minute questions as we start to close out the session. I perhaps want to highlight, I think stigma continues to be so pervasive across many aspects of our work. And I see it in communicable disease. I see the ongoing role of stigma in communicable diseases. And obviously it's been a theme in this session as well. Are there any strategies that you all have seen that have proven, or what do you think is necessary to continue to address stigma and to really create inviting spaces and settings for individuals to enter, particularly individuals from our Latino communities?
I guess for me, some of the things that I would love to do is have a clinician and a recovery coach in the emergency room to actually see the patients one-on-one. I think they're being tossed on the side, and they're not because of overwhelming of all the things that are happening in the emergency rooms. I think that's they're not getting that ability to work with people who understand them because they're not giving them the time to do that. So I think putting people in key places are important. I think the stigma still continues to exist. I think it exists from docs. I can't tell you how many places I go. I've seen, I went to get a haircut, and one of the folks that was there was a nurse from a hospital who was still calling them, "You can't believe the amount of junkies that are coming into into our ER." So we're constantly hearing that from all kinds of folks that's what's happening. And so it is a tough road moving forward. I know we call this a public health emergency. I don't think the rest of the community is seeing this as a public health emergency. There is so much that needs to be done to change our opioid epidemic. And really, we need those clinical people to be able to work with people. It needs to be a priority in everything that we do. And not only do we need to certainly work with our providers, but also with our patients themselves when they start talking about whether I'm clean or whether I'm dirty, and really for them to understand that addiction doesn't define them, and they don't have to go, I am so and so, I am an addict in recovery or whatever. It's I don't know, like addiction is defining them, and the reality is that they're no different than anybody else who has a disease process, and that's it. We don't define ourselves by what disease processes we have, and that they didn't do this to themselves, and that society did a lot of it to them, that we've put generations of Latinos back by incarcerating people and not giving them the ability to succeed afterwards. And a 6-month program in a treatment program is not enough if we call this a long-lasting entity. And so it takes more than just 6 months. And that support has to continue on when somebody leaves the program and continue to follow them afterwards. Otherwise, we become a revolving door or continue to be a revolving door. So let me go on.
I agree with Dr. Castiel. I think it's a social problem. I think, the fabric of civilization, we need to change the mindset, right? And we need to be active about it. It needs to start from grade school to primary school to universities, because it is a challenge. And so how can we institutionalize that mindset is something that we need to work on.
I'm linking an article that was published by Dr. Weiner and Dr. Wakeman. She does a lot of opioid use disorder work here at MGH. And basically what they found is that they looked at over 30,000 patient charts who had substance use disorder, and about 61% of them had very stigmatizing languages like abuse, addict, clean, dirty. And so, I mean, it's coming within the house, right? Like we have to really start working with not only with physicians, but also like providers at every level from very early on from their, so I think that one of the issues, one of the things that I've been experiencing, I've been doing substance use research in Latinos for over 13 years. And one of the things that I've been seeing, and maybe other people can also share their experiences, is that I think that there's a bigger push to making addiction care, substance use care as like general care, not only like specialized for this specific people, but make Suboxone, for example, prescribable by everyone. And that's one thing, but also to start the education very early on from, specific to MDs that was mentioned in the qualitative interviews, that really early in the medical school, really start teaching people how to, understand addiction from a very harm reduction perspective, use language that is not stigmatizing, because we study stigma. In the past, we study stigma as like self-stigma, like patients talk about them as a very self-stigmatizing, but a lot of the stigma is really learned from like how people talk to them and how they refer to them, right? So if we are wanting to reach the patient population, we really have to make a lot of adjustment. And like full disclosure, I've also like learned a lot about how to transform my own language during this process. And I used to say medication-assisted treatments. I learned that is actually also stigmatizing, just medication treatment. Why does it have to be assisted? So things like that, and being really willing to make adjustment. Just because you're a doctor doesn't mean that you know everything. And obviously, and just be humble about it, right? And I think that goes a long way.
Thank you so much. I think thank you so much to all of you for this enlightening discussion. I feel like a big piece of this, as we bring things together for a call to action, I feel like remembering that words really do matter. Like all our terminology at all points, our words really have a big impact as we think about stigma. And I think importantly that people have multifaceted lives beyond, and I think addiction and sort of the challenges that individuals face with addiction and substance use are but one aspect of their different challenges that they face across their personal journeys. And I think that learning how to connect with people, with humans, right, I think is something that often comes lost in these conversations, how we connect with people as a whole, understand the fabric of their lives, and understand how to help them as a whole, either like tackling food insecurity or tackling, challenges from immigrating from another country and not knowing the language and not having a job, or the isolation and sadness that comes with migrating communities. So I'm going to end us on a call to action. I I think we have a final slide with a few key questions, which is as we reflect, we're finalizing with 1 minute, what are strategies that we think can be better amplified to serve the Latinx community? What is the impact of all the actions that we're taking, and how can we make this happen? And I think as we round out and think about partnerships that can stem from this conversation is how clinicians, how researchers, how our own clients and populations and communities can all work together to assist in this efforts, I think is a huge takeaway from me from this interdisciplinary discussion, merging public health, merging clinical medicine, and merging research. So I want to thank everyone. I will turn it over to Dr. Fabián Torres Ardila briefly to close us off. And I just really want to thank Dr. Castiel, Mr. Dennis, and Dr. Zhen-Duan for this enlightening discussion.
Thank you very much, Sari, and thank you to all our panelists for being here. Thank you for all the participants. Just wanted to remind you that this is going to be recorded. This was recorded. It's going to be posted in the website of the Latinx Hub, the Latinx Knowledge Hub. And well, we pending on many other events that we're going to be planning. Thank you again for your time, and have a good day.
Everyone have a lovely Friday and weekend. Thank you so much.
Thank you, Sari.
1 second.
Thank you.
Thank you so much to everyone.